Hello, everyone. My name is Jennifer, and today we're going to be talking about the network specialized interview that we had to complete, and where we interviewed a social worker who has a specialty. Currently, I am interning for the U.S. Department of Veterans Affairs here in Delaware. They have 3 locations, the main hospital in Wilmington and then a clinic in Dover and Georgetown. I work or intern primarily out of the Dover clinic. But with that being said, the VA utilizes social workers in all 3 different areas. And what I chose for the specialized interview was to interview the suicide prevention coordinator, who is stationed out of Georgetown. So just some backstory on the VA and their stance on suicide prevention. So if you look on the VA's website, this information, it just says the VA's top clinical priority is preventing suicide among all veterans, including those who do not and may never seek care within the VA healthcare system. So what that means is that the VA has a stance to prevent suicide among all veterans, whether they're connected through benefits or with their medical system. So they really created this outreach program for the community, so they can bring awareness not only for veterans but family members and friends as well. Their initiative, I think, for this year is something about, making sure you ask. And what that means is just, whoever you come across, just ask, are you okay? How are you today? Because the VA believes that just by that simple question, that can open the door to, further gain a better understanding of what's, going on with that individual, that veteran. So I also wanted to just highlight the veteran suicide rate that was posted online. So the VA also posts data every year. The most current one I could find was from 2019. So it says, in the year 2019, 6,261 veterans committed suicide. The veteran suicide rate is 31.6 per 100,000 veterans. That rate is much higher than non-veteran U.S. adults. So civilians, people who were never in the military, the suicide rate for adults is 16.8 per 100,000 people. So as you can see, it's almost double the suicide rate than, like I said, for civilians. So for this interview, like I said, I interviewed the suicide prevention coordinator. Her name is April. I can never pronounce her last name, but she is a LCSW with the VA. So a summary of her current title role, she's the suicide prevention coordinator. She does the role management of veterans who have been identified for high-risk suicide. She provides clinical case management, as well as she advocates for veterans, and she's also considered a VA subject expert matter for suicide risk identification. April was clear in letting me know that for her program, suicide prevention, they use all evidence-based practices to identify suicide risk. She said high risk for suicide will go into VA health record for 90 days. So what that does, so if her and her team meets with somebody and they're identified as a high suicide risk, it creates a flag in the veteran's chart. So everybody who comes in contact with that veteran will then have a prompt of questions that they ask that veteran to ensure, that they're not at risk for suicide behavior or action. And then that stays in place for 90 days. So secondly, I had asked April, just a summary of her education and experience. She said she got in 2001, she got her BSW from Salisbury University. And then in 2003, she got her MSW. She became licensed as a clinical social worker since 2006. And so she says she's been in clinical practice since 2006. So she has a pretty good bit of experience. I had asked April what kind of tips would she recommend to build expertise in suicide prevention, and how how could new social workers build their confidence levels when, doing such an important role, such as suicide prevention among veterans. And what April had shared was that she said you get used to asking the questions without being anxious. So currently, when you are doing assessments with someone and you ask them, are you having suicidal ideations? Have you, had suicide attempts in the past? I know for me personally, sometimes that can be difficult to ask people. But as April was saying, that the longer you do it, the more comfortable you'll get with it. So she said that, you don't just jump right into it asking somebody if they're suicidal. You want to ask rapport building questions. How are you feeling today? How is your mood? And then you want to evaluate, is this person already coming to you in a crisis? She said it comes with a lot of practice, and ask open-ended questions, and just, keep asking questions to have them talking. But she said it's important to identify, like, are they coming to you in crisis, or is there something else going on? Because then that would change the approach that you have with the way you ask questions. I had asked April, what is one ethical dilemma that she may have faced in her practice and how was it resolved? April said that the biggest thing for her is that you have to be decisive in your decisions. So the ethical dilemma comes from, at what point do you ask family or friends to become involved? So like veterans, family, and friends for suicide prevention awareness. At what point would she, turn to the family and say, okay, this is what we need to be looking out for, things like that. So she said, by asking family and friends to become involved with the veterans suicide prevention plan, it can sometimes not align with like confidentiality, privacy for the veteran, and then especially if they're in crisis, you have to think those things through as well. I asked her, one question was, how do you avoid under or over reporting for suicidal veterans? What measures are in place to protect client self-determination? So April said that, you have to assess what are the risk factors for the suicide. Has there been enough experience? Has there been enough experience with them in their chart, or the red flags in the chart? And she said that veterans who present, they may not always be suicidal. It could be that the clinician is anxious and is not, making the distinction between a plan and an idea. Something that, April was pretty clear about when it comes to suicide. She said it's always pretty subjective. So as it relates to over or under reporting for, a veteran being suicidal, she said it's important to keep in mind that it's subjective. You got to get the whole clear picture of what the veteran is stating. And she said that, they have to have a plan and that they have to have intent. So, if they're being very vague in what they're, describing to you that they want to do, then she said that that is not necessarily a plan. It could just be something else is going on. So she said, through building your comfort with asking the assessment questions and gaining the experience to understand, what is subjective and then what is really going on. Because she said that sometimes can happen with other colleagues. You report things that are from a subjective lens when you really need to be objective about what is, the veteran presenting to you at this moment. I had asked April, how do you address and encourage diversity among your practice? She said one of their best practices, so they do assessments when they first meet veterans who may be suicidal. So April said you always ask upon first meeting any cultural influences or experiences that may be needed to help understand the veteran better. So she said they just come out and ask that question so they're not having to guess about it, and so they can understand what it is the veteran is truly experiencing, or what it is he or she may need to be effective with their care. Another question I asked her, are there any macro or advocacy projects that she's currently involved in or was involved in the past? And so she said, so April said that they mostly work on a micro level of social work. They focus on advocating for treatment to get moved to first of the line for appointments. So what April was explaining was that a lot of times she spends a lot of time advocating for veterans to get connected for treatment. So when we go back to what the VA's initiative was for suicide prevention for veterans, so the VA is taking the stance that all veterans are qualified for suicide prevention care. So that can sometimes cause a barrier. So if a veteran is not qualified for VA medical benefits, then here comes that advocacy piece where you have to advocate to the VA healthcare system that even though this veteran doesn't have the normal qualifications through his or her DD 214, they still need to have treatment because they're suicidal. So she said that takes up a majority of like her advocacy practice, just advocating to get the veterans connected to the care that's available through the VA. Another question I asked April was, how do you avoid burnout and what does she do for her self-care? So April said she really likes to cook to de-stress. She says she also has a good network of friends who are also in the social work field. So she said, it's helpful that, she has such close people that, understand what she's really going through when she goes to work. So she said, she cannot obviously disclose client information, but she can share generalities of, what's occurring and that they can understand. So she said that's really helpful. And then she said the VA every year hosts a continuing educational conference for suicide prevention that's about a week long. It's usually in a different state every year. So she said her and her team, they get to travel to the conference and then they get to be with other professionals who are providing suicide prevention throughout, the whole country. So she said that's really a good time to connect with other peers. And she really enjoys, going to these conferences, listening to stories about what's working for other people, what's not working, things like that. I wanted to ask April, what was the average length of time one social worker may occupy the role of a suicide prevention coordinator? Because the VA likes to place interns with more than one social worker, so you get a pretty vast experience of how social workers are utilized throughout the VA system. And one of the social workers I came across, he used to be a suicide prevention coordinator, and he said that he really burnt out after about 4 years of being in that role. So I was just interested to see from April's perspective what that looked like for her as far as like the burnout rate. So she said, of course, in her specialty with suicide prevention with veterans, that the burnout rate is really high. She said that, the people on her team, her and herself, they talk to people in crisis every day. So it's a lot of pressure for social workers to engage clients or veterans who are not always stable. April shared that, the average length of time a social worker would be in a suicide prevention role is about, excuse me, 4 to 4.5 years. April said she's been in this role about 3.5 years. She said so far she doesn't feel burnt out, but it goes back to those self-care techniques, making sure you're taking care of yourself, things like that. I had asked April how many staff are in the program and what is done for employee morale to address vicarious trauma. So April said what is very helpful, they have a staff of about 4 social workers, all LCSWs, licensed clinical, clinicians, and that they operate as a team. So it's never one social worker making a decision. So if April's picking up on something that she thinks may be important, then they would discuss it at their meeting. They meet about, I think she said 3 times a day. They talk as a team. team. So if one social worker picks up something, then they talk about it as a team to make sure, again, you're not overreacting or underreacting to what's being presented. And so April just shared that kind of modality is very helpful, because if she's feeling tired or something, she may miss something, but one of her teammates would pick it up. The last question I asked April was, what motivates her to do this kind of work? Is suicide prevention outreach, something that she ever thought she would, be interested in. And April, said what motivates her is to just, be helpful to people and help them, see that things aren't always as bleak as they may appear. So, it really motivates her to help people, change their lives and become more independent. And so those were the end of my questions with April. I think my biggest takeaway that I got out of talking with her was that, suicide is subjective, and that, you need to remember, the intent and the plan. Having the conversation opens the door to understand more of what's going on with a veteran or just, anybody. But just remember that it's subjective. And so, to keep yourself from overreacting or underreacting, to keep that in mind. And, prior to coming to the VA to intern as a social worker, I hear a lot that, veteran suicide rate is high. You hear a lot in the media and such that, 22 veterans a day will, commit suicide. So I don't know if it's something that, people really take seriously. But just in my limited experience at the VA, we did have last week one of the veterans on our HUD-VASH caseload did commit suicide. So that experience, I guess because experiencing it with the team, it really did hone in for me that this is really serious. This isn't numbers on a in the news or on the computer or in a textbook. Like this really is happening. So it's very important for people like April and her colleagues and even the other social workers and professionals in the VA to really understand what's going on and then have the appropriate amount of training. So that way, you can help all veterans in need.